Hello, everyone, and welcome to Got a Problem with Your Knee? Ask Dr. P. My name is Luciano Vigilati. I am a VFit specialist here at Victory in Motion, the home of knee repair, not knee replacement. We are so excited to welcome you to our weekly show. We have a ton of questions that were submitted to our school group, Got a Problem with Your Knee? Ask Dr. P, our Facebook group, Knee Repair, Not Knee Replacement, and our social media accounts at Victory in Motion 1. First thing is first, who is Dr. P? Dr. P is a board certified orthopedic physician, a sports medicine specialist, and a regenerative specialist. He is the founder and CEO of Victory in Motion and the creator of the trademark Knee Repair, Not Knee Replacement program. Victory in Motion's mission is to make the world knee replacement free by 2043. Yes, you heard that right. Knee replacement free by 2043. Dr. P has over 25 years in orthopedic and regenerative medicine, so he brings a wealth of knowledge every week to the show to be able to answer your burning questions. So, without further ado, let's welcome Dr. P.
Hey, Lucci, good to see
What's
you.
up?
Hi, everybody out there. Another week
Another
went
week.
by fast.
Yes. So, we got a good list of questions today, and I think we should just get right into it. So, the first one that we have is it more important to have full knee extension or full knee flexion?
Okay, so is it more important to have full knee extension or full knee flexion? So extension means going straight, flexion means bending it. Obviously, they're both important. Probably what's technically a little bit more important is extension because when we walk, that knee has to kind of get into full extension as we're about to push our toe off. And if you don't and it's bent, it's going to cause abnormal stress on other areas of the body. It's going to make you limp, and it's also going to usually lead to pain in the front part of your knee. However, if you can't bend your knee, then that makes it difficult to squat or kneel or eat, or do those types of things as well. So both are not necessarily good to have limitations, but extension is probably a little bit more important than flexion if I was going to rank them, but not much.
Okay. The next one we have, the question is calcification possible in the knee? I think that it'd be good to start with what is calcification, and then we get into is that possible in the knee?
Great. So is calcification possible in the knee? Yes, calcification is possible in the knee. Calcification is just, it's not from eating too much calcium. It's just as we get older, sometimes our tissues break down and the cells die. And normally our cells pump calcium out of themselves, but when they die, the calcium goes in and you get calcium deposits. So it's usually a sign of degeneration or damage, calcium deposits. You can get calcium deposits, hardening of the arteries, right? That's a sign of damage to the lining of the arteries. And people hear about that all the time. That's a form of calcification. So as we get older, the different parts of our body, as they degenerate, can start to calcify as they break down. So we see calcification within the cartilage of the joint. We have cartilage on the end of the bone, which looks like the white on the end of a chicken bone. That's like the tread in a tire. When that wears down, that's what arthritis is. We also have the meniscus cartilage, the little shock absorber cartilages in between the bones. That's the type of cartilage you hear about, like when an athlete tears the cartilage in their knee and has to have arthroscopic surgery. So chondrocalcinosis, chondro means cartilage, calcinosis means calcification. We do see calcification of the cartilage sometimes, and that's usually the sign of an injury or, unfortunately, most commonly, aging. It doesn't necessarily mean you have to have pain. It can cause inflammation and pain, but we see people who have chondrocalcinosis who have no symptoms at times. But yes, you can get calcification in that regard. You can get calcification in tendons, especially where they attach to the bone. So the quadriceps tendon that attaches to the top, the superior part of the kneecap, and the patellar tendon that attaches to the inferior part of the kneecap, we will frequently see small calcium deposits there because that's an area of high stress from running and jumping and beating your body up over your whole life. And so those areas will sometimes degenerate and calcify, fill in with calcium as those cells die. We sometimes see loose bodies in the knee. Loose bodies can be made up of a piece of bone and or bone and cartilage, and bone has calcium in it, so they show up on an X-ray. That's kind of another form of maybe calcification. People form spurs. We haven't really talked about that, but as the cartilage, the tread wears down, more and more force gets transmitted to the bone underneath. the bone tries to spread that force over a wider surface area. So it actually widens your bone, forming these bone spurs. The bone spurs are not the cause of arthritis. They're the result of arthritis. And sometimes those bone spurs, first of all, they're made of bone and calcium, but also they can break off and get into the knee and form a loose body or a quote joint mouse. So yes, we can get, those are just a few forms of calcification of the knee.
Yeah, sounds good. So kind of just like a follow-up on that is, so say somebody did have calcification in their quad tendon, would our regenerative programs be able to treat that? Or what would be is that possible with what
Yeah,
our
great
program?
question. Yep. So since calcification is usually the result of wear and tear or degeneration or breakdown of tissues and tissues dying, usually tendon tissues don't have a very good blood supply, so that's why they're more prone to breaking down anyway. And so if we can increase the blood supply to the area, a lot of times we can either stimulate the cells that are there to start growing again and healing and new blood vessels to go into the area. So laser therapy, certain wavelengths of light, increase blood flow to the area, decrease swelling and inflammation. But increasing blood flow, we found sometimes calcium deposits, for instance, even in the shoulder, big rotator cuff calcium deposits or calcium deposits in the kneecap tendon will sometimes go away just with laser treatments. But you're right. Just making the calcium deposit go away by increasing blood flow, it might not be enough to really fill the area back in with healthy cells. And as we get older, we have less stem cells and other cells that are repair cells. So we can oftentimes help our own bodies heal ourselves. Our bodies have an amazing ability to heal ourselves. But as we get older, that lessens. So we can take good stem cells from the pelvis, not the hip, not the spine, the pelvis, right underneath the skin, kind of in the back part of your upper butt area. And we can numb that up in the office. We can take good cells and we can inject those into the area where the calcium deposit is or the degeneration is and kind of reseed the area. And then we can also add PRP, which is platelet-rich plasma, which is kind of like fertilizer. It has growth factors. So we put the cells in, kind of like grass seed. We put the PRP, the platelets, which is kind of like the fertilizer. And then we use the laser, which is kind of like sunlight, and we can get those areas to heal and the calcium deposits many times to go away and those areas to fill in. So we see that on MRI after we repeat the MRI and X-rays. So the answer is yes, regenerative medicine techniques work very well for degenerative calcific tendon problems.
Nice. The next one that we have is, can I walk if I have a torn ligament in your knee?
Can I walk if I had a torn ligament in my knee? And the answer is most of the time, yes. It kind of depends on what ligament is torn, and it depends on if you just got injured in a basketball. Let's say you're playing basketball and you tear your ACL. Most people aren't going to want to walk right away after that because they're in a lot of pain. But can you walk with a torn ligament? Torn ligament is really a sprain. A sprain is an injury to a ligament. Ligaments connect bone to bone. So our knee has four main ligaments. It has the MCL on the inner side, the medial collateral ligament, the LCL on the outer side, the lateral collateral ligament, and then your ACL, anterior cruciate ligament, which most people have heard of, and the PCL, which is more in the back of the knee. So let's say you tear your ACL. Initially, it's going to swell up, it's going to hurt, and you're going to limp on it. But as the swelling goes down, and the pain goes away, people can usually walk on it. It's a question of whether or not it'll be unstable and start giving out on you because ligaments hold your bones together to prevent there from being instability. And so most people can walk after they've torn their ACL and the swelling goes down, and maybe they get in to see a rehab specialist like you. But turning and pivoting can sometimes cause that knee to give out. Sometimes early on, you don't want to be excessively walking because that's going to cause more inflammation, more swelling. You want to get that swelling down, get the range of motion back, and then the walking can come. So it's really important to get in to see an orthopedic surgeon. We deal with bone and joint issues all the time, sprains, ligament tears, etc., and especially to a physical therapist, physical therapy assistant, athletic trainer, and in our case, you guys are all strength and conditioning specialists as well. So someone who is well versed in the rehab and the recovery from these type of injuries. So the answer is yes. In the correct circumstances, people can walk with a quote torn ligament. Sometimes it requires a brace. It should require usually some rehab, and sometimes it does require surgery if the knee becomes unstable and keeps giving out if that ligament doesn't heal.
Yeah. I got a little follow up for that. How long do ligaments take to heal?
Right. So there's different grades of ligament tears, or let's say sprain, because sprain is the official name for a ligament injury. And so a grade one sprain is just a little bit of a stretch. You can't even see it on an MRI usually a lot of times. Maybe a little bit of signal, but no structural tearing, maybe microscopic tearing. Grade two is some partial tearing. So there is some structural tearing, but it's not torn in two. And then a grade three is it's completely torn in two. And those can sometimes heal in the case of the MCL with a brace and the proper rehab, but sometimes those need surgery, like an ACL. Most complete ACL tears aren't going to heal and need surgery, not all. So I would say for grade one, actually for any of these things, it can take on average 3 weeks to 3 months. But if it's severe enough to need surgery, it can take 4 to 6 months to get back to full duty type activities. And in the case of an ACL tear that needs surgery, it can take 9 to 12 months to get back to full duty type activities and including sports, but sometimes even longer than that. So in general, a sprain is going to take 3 weeks to 3 months if it's non-surgical. If it's surgical, it's going to probably take at least 4 to 6 months, sometimes even a year or longer to fully recover.
Right. And how would I know? This is the next question. How would I know if my knee pain is arthritis?
So how would I know if my knee pain is arthritis is the question. And um, well, let's talk about the symptoms first. So the symptoms are usually you notice that you have more than normal stiffness in the morning when you get up. You know, your knee is stiff when you get up in the morning, and we're all a little stiff when we get up in the morning, but it's just getting worse. It takes longer to get going. So mo morning stiffness takes longer to get going. It starts to swell up. You notice more noises in it, clicking, popping, snapping. There may be some buckling or giving way, not true instability, but you get an episode of pain going up and down the stairs and your knee buckles. You may start losing range of motion. It starts getting stiffer. These are all signs of arthritis. Arthritis doesn't always hurt every day 24/7. It's usually stiff in the morning. You get moving and you loosen up and it doesn't feel as bad. And maybe you're not thinking about your knee as much. And then as the day goes on, it tends to swell up, get a little stiffer. And then at night, when you go to bed, it's pretty sore and swollen. And sometimes it keeps you up at night. So that's kind of the symptoms. Now, the way to diagnose arthritis is usually an x-ray is one of the best ways, especially a weight-bearing x-ray where the person is standing up. Because if you get an x-ray lying down, it may look like there's more space between the bones than when you're standing up and actually putting weight on it. And there isn't actually a space between the bones. There's cartilage. And there's cartilage on the end of the bone, and there's cartilage in between the bones. And cartilage normally does not have calcium deposits in it. And so it shows up like a space on an x-ray, whereas bone has calcium and bone shows up white on an x-ray. So if that space, or we call it joint space, but if that space is narrow on an x-ray or even bone on bone, that's not really a space. That's how much wear and tear there is on the tread on the tire and how much cartilage wear and tear there is. And that's what arthritis is. So the narrower the quote unquote space on an x-ray, the more arthritis there is. So arthritis is very well diagnosed. On x-rays. Now, sometimes people have rheumatoid arthritis or lupus or gout or Lyme disease that can cause wear and tear on the cartilage, your body attacking itself, and autoimmune disease. That can sometimes be diagnosed with a blood test. So you need a blood test to test for rheumatoid factor, or there's a specific test for lupus. There's a specific test for gout, things like that. And so sometimes blood tests or even taking fluid out of a knee, we can analyze it and see if someone has arthritis, such as gout. And then MRIs are good. I think I like X-rays for in general, but MRIs will also show cartilage wear and tear. And what the MRI shows that an X-ray is not going to show is the stress or microfracturing underneath. So some people will not have a lot of wear and tear on their cartilage yet. They have this pain and all these symptoms are just starting. And so we'll get an MRI, and the MRI will show these white spots in the bone underneath the cartilage, these soft spots. They're called stress or microfractures, and bone has millions of pressure sensitive nerve fibers in it, so it hurts. So most of the pain from arthritis actually comes from the bone. And if we can catch that early enough, and you can only catch this with an MRI, we can oftentimes cure the stress or microfractures, get them to heal, usually by injecting stem cells and other cells that help the stem cells from the bone marrow, PRP, things like that, using laser, all those things we talked about. And if we can get those soft spots to heal, that the cartilage over the top won't break down, or if it's already starting to break down, it'll slow down the degenerative or the arthritic process. So people who get those stress or microfractures in the bone, they're 9 times more likely to go on to need a knee replacement. So all the more reason a lot of doctors will say, "Oh, you don't need to get an MRI. You have arthritis." Well, if you have those soft spots, you can't diagnose those by X-ray. And if you miss those and you let them get worse, that person's going to go on to develop arthritis a lot faster. So we almost always get an MRI as well.
For sure. Never safe to just assume that it's arthritis. It's always good to, confirm it and that you can really find a true plan to get you back to where you need to be. So that goes into our next question. So you get your MRI, you get your X-ray, and you find out that it's arthritis. Is there a way to reverse your arthritis?
So can you reverse arthritis? That's the question. And the answer is sometimes, but many times no. So if we catch it early enough, like I was just talking about in that last segment, and we catch the soft spots or the stress or microfractures in the bone underneath the cartilage, the subchondral bone, if we catch that early enough before there's a lot of cartilage damage, before it's kind of like the surface of a road. If that underlayer gets soft or washes out, that upper layer, the asphalt, is going to break down and you're going to get a pothole. But if we can reinforce that underlayer before that upper layer breaks down, you're not going to get a pothole. Or if you do have a pothole and you reinforce it, it's not going to continue to expand and get bigger. So we can, if we catch it early enough, we can reverse or cure arthritis. Absolutely. But that's unfortunately rare with the current medical system we have because we're not proactive, we're reactive, and we wait too long. And the people come to us much further along in the process than they need to. And then at that point, we can't cure the arthritis. We can slow it down or stop it. So if they've already got some wear and tear on the cartilage or these potholes, and we reinforce that bone and we clean the inside of the knee up and we inject some bone marrow, which has stem cells and other cells that help the stem cells, and PRP, platelet-rich plasma, which is kind of like fertilizer. And we use laser and we correct any mechanical defects and we correct any muscle imbalances and we work on their whole body, not just their knee. A lot of times we can halt or slow down or stop the progression of the arthritis, and we can definitely reverse or eliminate the symptoms completely. So once they have arthritis, it's hard to cure it, but we can definitely make it a little bit better. There are a few studies that show we can grow back some cartilage. There's definitely studies and personal experience where we can make the bone heal, so we can cure that. But a lot of times we can't make an 81-year-old knee look like an 18-year-old knee. Now, if somebody has a rheumatoid arthritis or a lupus or a gout or an inflammatory arthritis where your body is attacking itself, it's hard to cure that. Well, if it's Lyme disease, you can cure that. Not always, but sometimes that can be cured by taking antibiotics. But if it's gout, we can control that by taking medication. If it's lupus or if it's a rheumatoid arthritis, a lot of times those can be controlled by taking medications and halted or slowed down, but really not cured. So I think the answer was, can you reverse knee arthritis? If it's very, very, very early on, yes. Most of the time, if it's gotten to the point where they're, pretty far along or too far gone, our goal is then to eliminate it from getting worse, eliminate the progression, maybe slightly improve it, but then definitely eliminate the symptoms and the functional problems. So make sure you have no pain, no swelling. You can walk normally. You can go up and down the stairs. You can play with your grandkids. You can golf. You can play pickleball. You can hike. All those things. We have people with bone-on-bone arthritis that we can get to those levels. So yes, it kind of matters what the X-rays and MRI and everything show, but really what matters is what do you want to do? What are your goals? And can we get you back to those goals? Can we reverse you back to, you weren't able to do those things before, but now you can do them? Yes, we can definitely do that.
Yep, and we do it every day, really. So say somebody got diagnosed with arthritis. They want to make it better, not fully reverse it, obviously, because you can't fully grow back all that cartilage. But they're scared to run on it, scared to walk on it for long periods of time. They're scared to do certain movements because they don't want to make it worse. Does exercising make arthritis worse?
So the question is, does our wait, okay, let me get this right. So the question is, does exercising make arthritis worse?
Yes.
Right. Okay. So, and you mentioned a few different types of exercise, running versus other types of exercise. So, in general, exercising is usually not going to make arthritis worse if done the right way, and especially if supervised by your orthopedic provider, your regenerative medicine provider, and especially by your rehab provider. In our case, it's VFit because we work on the whole body. So, in general, the answer is exercising does not make arthritis worse. Having said that, there are certain types of exercise that once you have arthritis, we don't always recommend because there is some evidence it can be made worse. So, running or impact loading exercise, jumping, those are not necessarily indicated for people who have moderate to advanced arthritis. And you don't know if you have moderate to advanced arthritis without getting in to see your orthopedic surgeon or your orthopedic provider or regenerative medicine provider or your physical therapist, your rehab specialist, etc. So you would need a good diagnosis first to really, and that's why we do that comprehensive diagnostic evaluation where we'll spend an hour with somebody going over, their past history. We'll work with them on getting their whole history. We'll get a set of X-rays, like we talked about, why X-rays are important for arthritis and diagnosing it. We'll get an MRI because that is going to show you if there's any soft spots in the bone, and we know we can cure those. We get an ultrasound too, which we didn't talk about, and that is going to show us live how the knee is moving, if there's fluid in there, how the different structures are working. We can see tendon issues. Sometimes we can see tendon issues better when we're moving the knee than a static image or a one-time image of an X-ray or an MRI. And then we'll have them go over to our VFit, total body fitness, strength and conditioning, and one of you guys will completely evaluate their whole body, not just their knee, because we know the hip can affect the knee, the ankle can affect the knee, the back can affect the knee. And then we also want to know what your goals are. So if someone's goals are to get back running and they have bone-on-bone arthritis, we won't necessarily recommend that. But if that's really what they want to do, then we're going to figure out every possible way we can do to get them back doing that, even though that may not be the best exercise for them. So in general, exercise does not make arthritis worse. But if there is a type of exercise that could make arthritis worse, if not handled correctly, it would be, running or impact loading or jumping exercise, those type of exercises. So there's plenty of people who say, I don't need to run anymore, and they'll ride a bike, they'll swim, they'll aqua jog, they'll use an elliptical. And frankly, getting underweight, strengthening, we know is a lot more important than it was given credit for as compared to cardio over the years. Cardio is still important, but strengthening as you get older and building muscle mass and correcting imbalances and your muscle and correcting alignment issues and things like that is very important long term. And the more muscle you build, the more shock absorber there is. So maybe you are able to get back to doing a little bit more impact loading exercises. Like, can I get back walking? Can I get back hiking? Yeah, I used to run marathons, but I want to hike now and I want to walk for exercise. And we can get most people back doing that. So it's a loaded question, but in general, exercising, if done properly, will not make arthritis worse.
Definitely. I think the key there is if done properly. You don't want to go in and, after taking months and months off of the gym and think that you're still where you were at. Definitely progressively loading yourself to get to the back to where you were is important to not put excessive strain on the joints. Um,
We see that all the time. People, they've taken, they used to whatever. They used to walk their dog 5 miles a day. It's been 3 years since they've done that because of their pain. We get them feeling better and they think they can go right back to 5 miles. You can't. You got to progressively load and progressively slowly increase. But many people can get back to that. It's just you don't want to overdo it too much too soon.
100%. The next one that we have is can weight gain cause knee pain?
The answer to the question of can weight gain cause knee pain is yes, in general. Um, there are studies that show that obesity uh, and people who are obese do have more incidence of knee pain and knee arthritis, and frankly, need for knee replacements. There was a study, I think it was done by Messier I think it was the one of the arthritis journals, rheumatology journals, and I think around 2005. And it showed that people, for every pound of weight that people gain, that adds 4 to 6 pounds of force across the knee. And so even if that's not exact, because let's say it's 2 or 3 times or even more, it's still for every pound you gain, you actually put quite a bit more force across your hips, your knees, your ankles. And so but the reverse of that is if you just lose a pound, you're taking 4 to 6 pounds of weight off your knee. If you lose 10 pounds, that's 40 to 60 pounds. So you can, but just by losing a little weight, 10 pounds, 20 pounds, and who doesn't want to lose 10 or 20 pounds, you can take a significant amount of force off of those knees that are giving you pain. And we have had many people lose weight and their lower extremity pain gets better or goes away. And we have programs to do that, as you know. But I'll give you the example of this one guy. He was 368 pounds and his name is Tom, and he had hip and knee problems. And he came to me and he said, I want you to do, stem cells and PRP into my hip and into my knee. And I'm like, well, we take the bone marrow, which has stem cells and other cells that help the stem cells, and we take the PRP and we put it in, but that's going to put a lot of force on it. I know it'll help you, but in the long run, it's going to not work as well. So let's try to lose the weight first. So he went through, we test their genetics and we found out what the best diet was for him based on his genetics. And he got a diet coach for 3 months. And he also did red light laser, which is a little bit different type of laser. Our fat is stored in fat cells. And so certain wavelengths of light actually open up the pores on the fat cells, and the fat will drain into your lymphatics and it will be excreted out naturally. And that's kind of a jump start for people to help them lose fat and lose weight. So he was 368 pounds. He lost 103 pounds within 6 months, and he's not even a year into it. And he's lost, last I just talked to him last week, 115 pounds. And now he has almost no hip and knee pain. So pretty amazing that, quote unquote, just losing weight can help decrease the hip and the knee pain. So the answer to that question is yes. And yeah, putting a pound on adds 4 to 6 pounds of force, but conversely, just losing that 1 pound will take 4 to 6 pounds of force off. So it works in reverse as well. And get that 10 or 20 pounds off, you're going to notice a difference most of the time.
100%. And that's with every step, correct?
You reset.
Every step. So that builds up quick, that adds up. Yeah.
You just even imagine taking 6 pound weights, which isn't very much, right? And strapping them to your knees, and walking around for the whole day. Do that for a day. Then maybe a 5 pound ankle weight, put it around your knee, walk with it for a full day, and then the next day don't walk with it. You're gonna notice a huge difference, even just 5 pounds. So it makes a difference.
Yeah. That's what I did when I was a kid in my book bag trying to jump higher.
Hey,
Walk around with
perfect.
some rocks in
Yes.
my book bag. But okay, next we have is why does my knee lock up?
Okay, the question is, why does my knee lock up? There's a lot of reasons for locking. Probably the most common is that the meniscus cartilage, which is the shock absorber cartilage in between the bones, that tears and a piece flips back and forth. it's unstable, and when it gets in between the thigh bone and the shin bone, it locks the knee up. The knee can't go all the way straight, and unless it flips back into position, the knee is locked, and it's very painful. And sometimes you have to manipulate it to get it to go back into place. Sometimes you have to actually go into the operating room and do surgery because you can't get it unlocked. And then, unfortunately, if you have a piece that is unstable like that, which I had in the past, usually that needs surgery. And if it's a flap where it's just flapping back and forth, usually we just go in and trim that out. That's called a partial meniscectomy because those are usually not repairable. If it's what we call a bucket handle tear, and I've done a bunch of posts on this, sometimes we can flip that back over. Even if it's a huge tear, we can sew it back together. Maybe we can add some bone marrow cells, which has stem cells and other cells that help the stem cells. And we can add PRP, platelet-rich plasma, which is kind of like fertilizer to help that healing. And we can get that meniscus cartilage, that shock absorber cartilage to heal and stop flipping back and forth and locking up the knee. So meniscus tear, probably the number one reason for locking of a knee. Number two, what we call a loose body. I talked about when people get arthritis, they can develop these bone spurs, which can basically break off, and those bone spurs can get into the knee and get loose, and it float around. They call them a joint mouse because they're all over the place and they're hard to catch. Especially even when you go in and do surgery, they're floating around the knee and they're hard to kind of get. So if that gets in between the two bones as well, that's going to hurt, and you're not going to be able to straighten that knee. So loose body can cause the knee to lock up. Um, you can have the lining of the joint, the synovium, get really thick, or some people have a disease called synovial chondromatosis, where the lining of the joint turns into a bunch of these little loose bodies. It's a metabolic problem. We don't even know the exact cause a lot of times, but they'll get these little things that break off and form in the knee. And that oftentimes needs surgery because you have to go in there and shave all those away and shave the whole lining of the joint. And sometimes they can come back again. So loose bodies, the lining of the joint, meniscus tears, and then some people describe locking, but it's really not locking. It's more of a buckling or a giving way. And if your knee's not getting stuck in a bent position and you don't have to shake it out to get it straight, it's probably not a true locking symptom. And that might be a muscle problem, even a nerve problem. Um, so we have to really distinguish, is it really truly locking? So x-rays, MRI arthrogram where we inject dye into the knee, and that way if there's something loose floating around, the dye will go around that loose thing and we'll see it much easier, the contrast. So those are ways we can test for that. Sometimes going in there and looking is the only way to know for sure, and that's arthroscopic. And sometimes if there's something loose floating around in there, most of the time, that's going to need surgery to go in there and pluck it out. There are rare instances where that loose body will float around to the back of the knee, outside of and being in between those bones, and it will scar down, and it'll never bother the person again. So there are rare instances where a loose body will not need surgery, but most of the time, or many of the times, it does.
For sure. Yeah. So you don't really know until you know. You know, there's multiple things that can lead to locking up. Um, the next one you were talking about some nerve stuff. It's can the back contribute to my knee pain?
All right, so the question is, can the back contribute to my knee pain? Absolutely. We see that every single day. We have nerves in our back that run down and form, well, we have nerve roots that come out of our spine that turn into nerves that go into our arms and our legs. And, in the case of the legs, all the way down even into the toes. So you can have a herniated disc or a pinched nerve in your back that's giving you pain in your toe. So can it give you pain in your knee? Absolutely. And that's where seeing someone who's trained in evaluating the back and the knee, like an orthopedic surgeon, a regenerative medicine specialist, a rehab specialist, a V-fit specialist, is very, very important. And that's why it's so important that when we see people, we do have you guys over in the V-fit department see these people and evaluate everything from head to toe, because we do find that even if there is a knee problem and there's some arthritis in the knee, a lot of times it's exacerbated or being made worse by an irritated or a pinched nerve in the back. So it's very common to have back issues superimposed on hip and knee and lower extremity. pain and issues. Very common. We see it all the time. My question to you would be, what percent of people do you see with knee pain who have a back component as well? This is obviously, this is just your experience, but what would, in your experience, what is it?
Honestly, it's anywhere from like 40 to like 65% because a lot of times people still do have knee problems, but their back is still contributing to it. So yeah, I would say around at least 50% most of the patients where, they still do have knee things going on, but the back is contributing to it. But there are times where it's majority of the back and you can get them walking out in a day feeling much, much better.
Absolutely. I was going to say it's at least 50%, right? And as we
Yeah.
get older, our knee, not just our knees degenerate, our whole body does, including our back and our neck. So, of course, there's going to be superimposed and other problems going on. And that's why we treat people in a holistic manner, because as you know, the hip can also give pain in the knee, and having issues in your ankle can give you pain in your knee. So, we try to take care of all those things as well. And it's at least, like you said, 40 something to 60 something percent. And even though it's not the back, the sacroiliac joint can give, I mean, people say, say, oh, I have hip pain, and it's really coming, it's most of the time coming from their back, but it can even come from where the pelvis attaches to the lower spine. That's less common, but it can happen. And sometimes that can even radiate down kind of toward the knee area as well. So it definitely can happen.
Yeah. Next one, I'm actually going to jump around a little bit on this list. Why does standing for prolonged periods hurt my knee?
Why does standing for prolonged periods hurt my knee? Well, prolonged periods means you're just standing there, you're not moving. So if we don't move, just like when you're in bed at night, you're maybe not moving as much and you wake up and you're kind of stiff. If you're just standing there and you're not moving, even when you're sitting in a chair for a long time, right? If you're not moving, then you're going to get some stiffness normally. Now, if you have arthritis, it's only going to make that stiffness feel even worse because it's going to exacerbate the stiffness. So, not moving makes arthritic symptoms feel worse. Not moving in general makes you feel kind of stiff. So, just not moving, so prolonged is the key. Now, standing is different. Lying in bed, you're not loading or weight bearing on that joint. If you're standing there, there is force, gravity, causes force, and if it's in the same position, that force is getting concentrated on one particular area, and it hurts. Just like if you're sitting in a chair and your butt starts to hurt, you kind of move around to distribute the force to a different area. But if you're just standing there like one of those, soldiers at Buckingham Palace, they can't move. And so, number one, not moving makes you stiff. Number two, just point loading almost those two spots on your knee for a long period of time can give you pain just in general. So, I think that's probably why prolonged standing uh, gives people knee pain. And if you have a tear of a meniscus or something in there too, and you're constantly putting pressure on it in one spot, and it just so happens to be the spot where the tear is, then that's going to hurt. So I think that's how I would answer that question.
Yeah. The next one that we have is why does my kneecap hurt when I kneel on it?
Actually, I was thinking about that, sorry to get back to the other question, but like, why does prolonged standing cause pain? Well, also, if you're standing there, those muscles aren't moving either. And so those muscles have to hold you in a position for a long period of time, and they get fatigued as well. So those Buckingham Palace soldiers, they'll isometrically contract their muscles to prevent themselves from also passing out sometimes because the blood will stay down. It will, gravity will pull the blood down from their brain and they'll pass out. So they squeeze their butt cheeks, they contract their quads, they contract their calf muscles. Not only does that help them stand longer by the muscles not over fatiguing, but also it pumps the blood up to the head. And then also, if you don't move your joints, you have your fluid in your joints, your synovial fluid isn't quite as lubricating either. So that's another thing I was just thinking of that can contribute to that. What was the other question? Sorry.
Oh, no, the next question was, why does my kneecap hurt when I kneel on it?
So the question is, why does my kneecap hurt when I kneel on it? Well, first of all, um, it doesn't really matter how large a human being is or how small a human being is. There's not a lot of cushion on the very front part of your knee where your kneecap is, right? And there's just not. So there's skin and there's pretty much bone. And so there's not much cushion there. So when you kneel on that area, there's not a lot of cushion and you can irritate the skin, which has a lot of nerves in it, and you can irritate the bursal sac between the skin and the bone. Wherever there are two structures moving across each other, like the skin over a bone of the front of the knee or the back of the elbow, or between two tendons or two muscles in our body, there's a thing called a bursal sac. A bursa is a little thin fluid-filled sac that lubricates two areas that are kind of articulating or going rubbing across each other, and it provides lubrication. It has a little fluid in it. So in between the skin and the bone, on the front of your knee, your kneecap, there's a bursa, prepatellar bursa. And if you kneel on that, that can get irritated and itis means inflammation. So bursitis is an inflammation of a bursal sac. And there's more than one bursal sac in the front of your knee, but we'll just talk about the one right in front of the kneecap. And that can swell up and that can hurt. And that's called, bursitis, but it's also, quote, water on the knee. That'll give you pain. Also, we just talked about standing for a prolonged period of time. If you're kneeling and you're not moving, you're causing a lot of pressure you're kind of scrunching your skin. And the bone, by the way, has nerve fibers in it as well. So you're putting a lot of pressure on those areas, and just that's going to hurt, especially if there's no cushion there. Now, that's the surface of the knee. Now let's go underneath the surface to where the cartilage is on the back side of the knee. If you have wear and tear of the cartilage on the back side of the kneecap or on the front side of the thigh bone where the kneecap communicates with, that's arthritis. And if you're rubbing arthritis against arthritis, bone has millions of pressure sensitive nerve fibers in it, and that's going to hurt. So, quote unquote, chondromalacia of the patella or arthritis under the kneecap can definitely cause pain in the front of the knee. Um, I don't know. Can you think of any other reasons why kneeling on the front of the knee would give them pain? I mean, if you have a stress fracture or something like that, if you're a basketball player like you and you have some tendonitis of your kneecap tendon, your patellar tendon, or your quad tendon, and you're kneeling on it for a long period of time, and it's already aggravated, that can hurt. Jumper's knee, right? Kneeling on a knee that's sore from jumper's knee, tendonitis of the patellar tendon, especially on a hard surface, is going to hurt.
Yeah, another one I was thinking of was maybe if the knee's not tracking correctly in the groove and it's not in its groove and you kneel on it, it's gonna put uneven pressure pretty much on the patella.
Absolutely.
Yeah,
Absolutely. So some people have alignment problems and their kneecap tracks or goes off usually to the outer side, the lateral side. And there's ways we can help with that by strengthening the muscles on the inner side of the knee, working on their alignment and their hip and all these other different things that you guys work on, tightness of their iliotibial band, all kinds of different things. But you're right. If that's not lined up right, it's causing abnormal pressure. That's going to hurt. We can get it lined up better. That can oftentimes help people who have kneeling issues or even just walking or running issues.
sure. The next one is, what is valgus knee positioning?
What is valgus knee positioning? Valgus is knock-kneed, okay, knock-kneed, whereas varus is bow-legged. So it says what causes valgus positioning?
Um, it says what is valgus positioning, but
Okay.
we can kind of
So yeah, what valgus positioning is just strictly knock-kneed. That is going to put more pressure on the lateral or the outer side of the knee joint. And those people tend to wear out the outer side of their knee, the lateral side, faster than the inner side of the knee, the medial side. That's less common than bow-legged, where you wear out the medial side, the inner side of the knee, faster than the outer side. But it's absolutely something we see. It's less common than bow-legged, knock-kneed, or valgus, but it's not uncommon. Now, one way you can remember valgus is it looks kind of like an L, so valgus has an L in it. So knock-kneed, valgus, if anybody wants to know, and varus is bow-legged. So L is valgus. knock-kneed.
Right. Yes, and that's what we see a ton in here. Getting that, like you were saying, the hips aligned, getting the hip, knee, and feet aligned together to move together as a unit, is key, and that is how we, correct valgus knee positioning is getting that alignment and get it strengthening up the muscles, of course.
Right. So there's dynamic valgus, which is much more common, and that's a muscular imbalance thing, and or there's other imbalances in tendons and muscles and capsules, the casing around the joint, and all those things that you guys can work on, and that definitely can be improved. Then there's also some people who are just, they're bow-legged or they're knock-kneed, and there really is no way that's their anatomy. It's just like some people are flat feet, some people have a high arch and that can lead to problems. But it's not totally abnormal, but there are certain parts of it that sometimes can be corrected. The valgus dynamic, meaning correctable alignment, that is huge, and that can help prevent ACL tears and other injuries to the knee. So if someone when they land from a jump, their knee goes into knock knee, even though they don't walk that way. That's what we're talking about. That's dynamic valgus. So they jump and they land, and their knees buckle inward, and it looks like a knock knee position. That is very dangerous, and that is very dangerous for tearing the ACL. And that is something that you guys do an amazing job. It's preventable, and we can lessen the risk of ACL tears. So if that's the question they're asking, absolutely, it's correctable. If it's someone who's got really bad arthritis on the outer side of their knee and their knees are like that, you can't really correct that without doing surgery.
Right, for sure. The next one we have is, do I really need a knee replacement?
All right, so the question is, do I really need a knee replacement? Let me just answer that this way. The answer is no, probably a lot more than people realize. There are studies that were done, and they have shown that knee replacements are probably done um, unnecessarily 25 to 30% of the time. So there are some people who failed everything, including regenerative medicine treatments, and the only option is a knee replacement. Absolutely, that's fine. But I think a lot of people are given two options. So they're given the standard options of, you got to do physical therapy and cortisone injections, which we know actually damage cartilage and make the arthritis worse. Gel injections with which insurance may or may not cover. Standard physical therapy, and the therapists are stressed because they only get, 15 or 20 minutes to work with a patient because they're told you got to see X amount of patients in a day. So they don't really get to work on the whole body and all these other alignment issues and muscle imbalances that we talk about. It's not their fault. They know how to do it, it's just they don't have the time. And so you go through that, and that doesn't work, or it just buys you some time, doesn't treat the root cause. And then you're told, hey, you need a knee replacement. And you say, well, I don't want a knee replacement. And then your options are, well, okay, you can suck it up and live with it, or, you get the knee replacement. Or you're told, well, you'll eventually need one, suck it up for now, but come back to me when you want it. And so, option one, suck it up. Option two, knee replacement. A lot of people don't know there's a third option, and that it has to do with a lot of the regenerative medicine techniques and things that we use and a lot of other doctors around the country use. And it's becoming more and more and more popular. Our bodies have an amazing ability to heal ourselves. As we get older, it lessens, but there are ways that we can, as we get older, we can concentrate those healing cells, those healing growth factors, and help your body heal itself and prevent the need or lessen the need for knee replacement. And I'll get a little bit geeky here really quickly. How do I know that? Oh, there's no studies on that, or there's no research on that. I'll give one classic amazing study. Dr. Philippe Pernigo, French orthopedic surgeon, late 1990s. He's like, hey, I do knee replacements on people, but I also know that as we get older, we have less good stem cells in our arms and our legs and our extremities, but we still have really good stem cells in our pelvis. What if we take the good stem cells from our pelvis, concentrate them, and inject them into the soft spots in the bone in a patient who has arthritis, who's been told they need a knee replacement, and will that work just as good? So he did an ingenious study. He had 140 patients. Every single one of those patients were told they needed bilateral, both knees needed a knee replacement. And so he said, okay, we're going to do a knee replacement on one knee, and we're going to do stem cells on the other knee on every single one of these patients. And we're going to follow them for at least 10 years. Some people were 15 or 20 years, but at least 10. So at the end of that study, 82% of the knees that got the stem cells never needed a knee replacement for 10, 15, or 20 years. And that's just using stem cells. And so if I told somebody out there who's been told you need a knee replacement, and I said, hey, you got about an 82% chance if we just do what Dr. Hernigo did, we do more than that, as you know, but if we just do what he did, you got an 82% chance of not needing a knee replacement for 10, 15, or 20 years. How many of you would take that? Almost everybody raises their hand. Not everybody, but almost everybody. And why not? Why wouldn't you want put little poke holes, little shots, as opposed to a huge incision, metal, plastic, and cement? If you get the metal, plastic, and cement, it wears out eventually. If it wears out, you can only do metal, plastic, and cement. If it doesn't work, you can only do metal, plastic, and cement. If it gets infected, even years down the road, like which happened to my father, 9 years after his hip replacement, it got infected. He had to have multiple surgeries, never got his hip put back in. If you get the regenerative medicine, if you go the regenerative medicine route and it doesn't work, you're one of those 18% who it doesn't work, fine, you can still get a knee replacement. So why not try every possible option you can try without surgery first? That's what we advocate for. So you don't, to answer that question, do I need a knee replacement? A lot of people don't. A lot of people don't.
For sure. Might as well try everything you can before, because there's no going back after. There's
No
no
going
going
back.
back once you get the metal and
None.
plastic in you. So, it's a
None.
next question we have is, are knee sleeves helpful for preventing knee injury?
All right. So the question is, are knee sleeves helpful for preventing knee injury? And the answer is no. I'll just say that. I mean, a knee sleeve is an elastic sleeve, like a copper fit sleeve or whatever brand name you use. And it might decrease swelling a little bit. It might provide some what we call proprioception. So it might make your knee feel a little bit better just because of the feeling of a little bit of security on the skin. It might make the knee warmer, so it might feel better. But it absolutely does nothing to prevent injury or prevent arthritis or any of that type of stuff. So it might make the knee feel a little better, does not provide any true therapeutic or root cause help, and it definitely doesn't prevent any injuries.
For sure. I definitely agree with that. It's a lot for people's comfort, really. Especially in the moment of like athletic events or while you're walking and things. It's more for comfort to help you feel a little more stable. Um, but I have a question of my own. We got through all these
Well, the key
15.
thing there is feel, because it doesn't make you more stable, but you might feel. So it's maybe
Right,
a false sense of security. But on the other hand, I mean, there's nothing wrong with wearing one if it makes your knee feel like it keeps it a little bit warm while you're playing a sport or provides a little compression if you have swelling. There are positive factors to it, but it's not going to prevent an injury.
right. And I got one last one. We got through our questions on here that were asked, but um, I think I have a good one. So, I was watching NBA playoffs and Jason Tatum tore his Achilles. I was wondering if regenerative therapy is um, indicated for torn Achilles, or is it just surgery?
Great. So the question is, can regenerative medicine treatments help an Achilles tendon tear like Jason Tatum had? And the answer is yes. Now, I don't know the exact extent of his tear. If it's 100% torn, um, then a lot of times that in an athlete that is going to end up in surgery. And why is that? Because there are studies that show that an Achilles tendon will heal whether you put it in a cast or a brace or do surgery, so it'll heal, but it will heal stronger and have less chance of rupture, re-rupture, if you sew it back together and do surgery. So for an athlete like him, if it's torn all the way, he's going to have surgery because the studies show less likely to re-injure it, and he can't afford to re-injure it. Now, what the studies are just catching up to is can regenerative medicine treatments like PRP, platelet-rich plasma, which is kind of like fertilizer, which helps with healing, or even better, stem cells or bone marrow aspirate cells, which has stem cells and other cells that help the stem cells. The cells do the work. So putting extra cells in that area because tendons don't have a very good blood supply which is one of the reasons they tear, and they don't have a lot of cells in them. So adding more cells, adding more fertilizer, more growth factors, we have found when we do surgery, helps with the recovery, helps with the pain relief, and helps with the healing better. I can't recall a single person we've used that on that's retorn, but I'm going to knock on wood. Now, we will also, for if you're not a professional athlete, and maybe it will get to the point where professional athletes will do this as well, but right now, they're all going to have surgery if they tear it completely. Now, if it's a partial tear, and it's not completely torn and it's just stretched a little bit, regenerative medicine, perfect. Don't do surgery. You're going to be out forever. You do the regenerative medicine stuff, you're going to be back in weeks or months versus a year. So partial tear is different. But for complete tears in the general population, we are doing a lot more where we are putting them in a brace and just injecting bone marrow aspirate cells, which has stem cells and other cells that help the stem cells, and the PRP, the platelet-rich plasma, into the area where the tear is. And we've had amazing results with that, especially in people who are older and just don't want surgery. They don't want to take time off from work. Yes, it still takes a while to heal. It's going to take you, 4 to 6 months to get back to full duty type activities, maybe less if we do the regenerative medicine techniques. But at least you don't have surgery. There's not as much downtime. And the one problem with surgery around the Achilles tendon is the blood supply is not very good to the skin either. And if that skin breaks down and you get a wound infection, it's a disaster, a huge disaster, huge disaster. And there's also nerve injuries that can occur. There's skin nerves near that area that tend to get irritated. So if you have a complication from that surgery, it can be a disaster. And so if you're not a professional athlete and you don't need to take that risk, a lot of people that we treat don't want to take that risk. They don't want the surgery, and we do regenerative medicine on them. And it absolutely speeds things up, but it's still a bit of a slow process, so it's not perfect yet.
Yeah, for sure. And kind of like we do with our bear surgeries, we go into surgery, but we still also get those uh injections in them because we know that we get better results with that just to help out that healing process. So for sure. Well, Doc, thank you so much for answering these questions today, and thank you to all of our fans out there on social media for submitting them. If you have a question you would like Dr. P to answer, be sure to join our school group link in the description below. As of the date recording, it is free to join. Be sure to follow us on social media at Victory in Motion One, and be sure to follow Dr. P on social media as well at Marc Pietropaoli, at Dr. Marc Pietropaoli. We will see you on Ask Dr. P next Wednesday at 9 a.m. And yeah, thank you, Doc.
Thank you, Archie. Great job. Thank you all for the questions. I know there's tons of questions being submitted on social media. We try to answer them as much as we can. Then we take the best ones, which you did a great job of today to ask these questions because they're very common questions. Also, if somebody wants to go to www.krinkr.com, so www.krinkr.com, you can learn more from an educational standpoint with a one-on-one educational consult. It's not a doctor's appointment, it's not a telemedicine, but people do ask a lot of specific questions, and we can only get into so much on these on social media posts and also on this weekly Q&A session. So join the Skool group so you can ask your questions live. But also, if you want to go to www.krinkr.com, feel free to do so. Continue to follow, comment, ask questions. We love it. Thank you.
Thank you. Well, we will see you guys next week.
See you next week.